Friends. I'm Dr. Chana Davis. I'm a geneticist, science communicator, and mom of 3 young children. And I'm joined today by fellow nerdy girl, Amanda Simanek. Say hello, Amanda.
Hi.
Amanda is a social epidemiologist with a PhD in epidemiological sciences and an MPH in international health epidemiology. She studies psychosocial determinants of infectious disease and links between infection, mainly herpes viruses, and chronic disease, most recently mood disorders. She is also a founding member of Dear Pandemic and a mom of 3 kids.
Thanks for
So,
having me, Chana.
yeah, thanks for being here. So I want to remind you all that we don't take questions cold, and that way we can have the latest and greatest information at our fingertips. We get our questions from the question box on the Dear Pandemic website, and we encourage you to submit your questions there at dearpandemic.org. So let's jump right into our first topic, and that is vaccines in young children. So, Amanda, what advice do you have for parents who are unsure about whether or not to vaccinate their young children, which now is as young as 6 months being eligible?
Yeah, I think my advice is that it's totally fine to have questions about it. And we are actually not going to cover very much about that today. I'm sort of going to punt that question because we just had a live Q&A with Dr. Malia Jones from Dear Pandemic team and Dr. Caitlin Jedalina from your local epidemiologist. And they did a live that was posted on our Facebook page and is available on our website. So I encourage you to go check that out. And Dr. Davis also just recently did a post helping think about what are the potential impacts of COVID-19 on young children, which I think does a really good job at sort of helping parents weigh, the risk benefits of vaccination that people may be considering. So it's okay to have questions, and those are 2 sources of information that we have available right now that you can check out.
Okay, I'll pop in the link. I hope this works. What is it? Just said can't post message to some channels. Okay, that's fine. I popped in the link to the post about the health impacts in young children. So that post was about what do we know about the toll of COVID in young children? Basically saying that, emphasizing this message that low risk is not the same as zero risk, and comparing the toll of COVID in terms of annual hospitalizations and deaths to other vaccine preventable diseases, where we see it actually has a greater burden than many of the diseases that we routinely vaccinate against.
Yeah, I think it's helpful perspective.
Yeah. And when I listened to that Q&A that on this topic with Malia, and one of the messages that really resonated with me is that, we think often differently about things that we do actively, like go get a shot, versus risks that we assume because of not taking action. And I think we really need to, not just with vaccines, but in all areas of life, actually, think seriously about the consequences of inaction. So I did a post on that on my page, actually, about just sort of broader perspectives on life and preventative health and all these areas where it's really important to kind of to just think about both sides of the equation.
Yeah.
And that's what the regulators do, right? That's what they're doing. They're making a risk benefit assessment.
Yeah. Okay, so we have some other questions that are also probably largely related to kids and thinking about summertime. And so one of them is, how likely is outdoor transmission from the Omicron variant or with the Omicron variant? And then should we be masking outdoors?
Okay. So I'll take that question. Yeah, it's funny because we have this Slack group where the nerdy neighborhood chats about all sorts of things of science and a lot of COVID. And it did come up. Someone said, "Oh no, there was a report of outdoor transmission at a camp." And I will say, anecdotally, I also have heard stories amongst friends. I mean, you don't always know 100% for sure, but we're definitely hearing more anecdotal reports of outdoor transmission. So it is not something that we can completely dismiss as a possible transmission environment, but it still is way lower risk than indoors. And I guess when I think about Omicron, I think sort of that Omicron floats all boats, right? So everything is like up a notch in how risky it is, but the relative ranking of activities remains the same. And so the same factors go into evaluating how risky something is. So what I would recommend is sort of thinking about that risk continuum. And, for example, if you're outdoors, you're going for a jog and you're passing one person for a second, that's about as low risk as it gets because you've got a short amount of time, you've got a lot of space between people, and you've got a lot of airflow. But a higher risk outdoor situation might be, a wedding that has a lot of people, maybe in a tent where there's not a lot of ventilation. And so you've got more people, more density of people. You're sharing more air because the air is not circulating. And duration of exposure is a huge factor. So are you sitting next to someone for 2 minutes, or are you sitting next to the same person for an hour? So those are the three aspects of the actual kind of environment that are really at play. But other factors really influence the risks too. Specifically, was there any pre-testing or any symptom kind of gating for who's at the event? Was there a requirement to be vaccinated? Things that can influence the likelihood of somebody being there. And of course, your local COVID rates will be a big factor as well to influence. So I know it's really complex. It can get exhausting to do this kind of risk calculus all the time. But so maybe we've been talking about just encouraging people to kind of develop a set of guidelines that maybe for outdoor play dates, I don't wear a mask, but maybe for indoor play dates I do, or whatever the rules that you are, but just sort of think through the basic principles first, and then maybe not try to get in a habit of just having set rules for set situations. What are your thoughts on that?
Yeah, I feel like I was answering questions about outdoor transmission 2 years ago, right? And whether we should be wearing masks. I think being outdoors is always safer than indoors, right? But you have to think if you're sitting next to somebody, talking to them at a baseball game for 2 hours and they have COVID, outdoors is not going to be magic in that situation necessarily protect you. So, I think it's those common sense things that you're talking about, like how crowded is it? Are you at a large concert, or are you at a picnic? Are you sitting right next to somebody, or are you, spaced apart? Those same types of things that we've been thinking of are sort of SMART framework that we have used with your pandemic the whole time about how you can just reduce your risk of COVID, and being outdoors is certainly one of the best ways in terms of improving air ventilation. But kind of common sense about how close you are in contact and for how long still going to matter.
Yeah. One sort of framework or way to conceptualize that I like to think about is the secondhand smoke. So if that person was, smoking, would you inhale a lot of their smoke, or would you just barely get a whiff of it? And that gives you a sense of your level of exposure.
Yeah.
So let's move on to a question for you. So a question about long COVID. So Lorraine from Vancouver, here's an example. She asked, for people 65 to 70 and other ages who are triple vaxxed, what are the chances of getting long COVID? And is there a difference amongst genders? And I know this is a really hard question to answer super specifically, so maybe you can just speak more broadly to what we know about how common COVID is and what are the different risk factors and why the estimates vary so much.
Yeah, so I think I'll start with thinking about why estimates for long COVID might vary so much study to study, because I think it's helpful to think about what goes into studies and determining that estimate in the first place before we kind of make an overall assessment of how common long COVID is. And then we can circle back to sort of what the sort of identifiable risk factors are so far. And so, when we're thinking about an estimate of long COVID from a study, I think we have to think about the points we have to think about is how that disease was defined and how it was counted, and who got counted as having long COVID, how that researcher might have sampled the population or determined who they would ask, from the population if they've had long COVID, the role that the way they collected that information may play in terms of whether it was voluntary through an app or through hospital records, the role of the timing that when they asked, because we've had different variants circulating at different times, which may have a different risk for long COVID, and then sort of the geographic location where the study is being conducted as well, because there just may be genuine differences in the prevalence of long COVID in different populations. So in terms of thinking about about how we count the number of people that have a disease or a health condition. We have to set criteria that constitutes what is a case of that condition or a case definition. And because long COVID is relatively new disease, it feels like we've been in the pandemic for a decade. But in the grand scheme of things, it's really been an evolving understanding of what long COVID is. Our definition or our thoughts about it have changed over time or have evolved. And so, now we may hear terms like post-COVID conditions or syndrome, long haul COVID, post-acute sequela of SARS-CoV-2 infection, right? So there's a lot of different terms that are also being used. And the World Health Organization sort of defines long COVID as a condition that occurs in individuals with a history or probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID, with symptoms that last for at least 2 months and can't be explained by an alternative diagnosis. CDC, on the other hand, thinks about those symptoms that are at least 4 weeks after infection. And that's like sort of the earliest when you could start to distinguish between just the acute symptoms of COVID versus post-COVID conditions. And then in the UK, the National Institute for Healthcare and Excellence defines duration as less than 4 weeks, 4 to 12 weeks, or longer than 12 weeks, with the last two categories counting as long COVID. So the first thing to do is pay attention in the study that you're looking at. Well, how did they count people? How did they define COVID? And is that the same as how they define that in another study that you're comparing the estimates between? In general, the symptoms that are sort of now thought of as common or potentially what people with long COVID experience are kind of wide ranging. So there's more general symptoms that are tiredness or fatigue, fever, and sort of symptoms that get worse with physical or mental effort. Then there's a range of other body systems that are impacted: respiratory and health symptoms, neurological symptoms, digestive symptoms, and other, body symptoms like joint, muscle pain, rash. So, there's a long list of symptoms that maybe are relevant to what people with long COVID are experiencing as well. And so there could be variation in sort of the symptoms that get asked or the way these questions are asked across studies. So another challenge then with figuring out how many people have any disease of interest is related to how you sample the population. Ideally, we would ask every single person, like in your city or state, if we wanted to know who everybody that was experiencing COVID, long COVID. But that's generally not possible, logistically really challenging. So then we have to choose how to administer a survey or collect that information. And it's not always going to capture a representative slice of the population. And so, we also think about who participates in studies as well. So there's, if a study is based off of a convenient sample of people that say, yes, I want to, know about long COVID, or I had long COVID, so please do ask me, that's totally different than sort of a sampling technique or asking people, who, regardless of maybe their interest in giving that information. And so then we also have to think about, as I started to mention, how information is collected. So are people using medical records to ascertain symptoms? Well, then that's really restricted to people who seek care for long COVID or for symptoms in general. Is it a app that people use on their smartphone to report symptoms? Well, that may be limited to people who use smartphones or who want to participate in those types of surveys, right? So I think paying attention to these ways that we collect data and who's included in the study can give some clue as to whether the people who ended up included might tend to be more likely to have had COVID or to have long COVID versus not. And then the time frame when the study was conducted in the cases were, detected matters too. I just posted recently on Dear Pandemic about how the risk of long COVID may differ by variant. And so maybe, Chana, you'll put that.
Yeah, I can put that link in
chat. So 2 studies that came out, one using population representative data from the UK and another using data from an app, so not necessarily population representative, both found that the risk of long COVID was higher with Delta than Omicron, but that the BA2 variant of Omicron, the risk seemed a little bit higher than BA1, and we don't yet know about BA4 or 5 or any to yet emerge variants. So I think paying attention to all of those, characteristics of the study can help us figure out, if we're really comparing apples to apples when we're looking at different estimates from different studies, and can also help us evaluate, hey, is this study sort of a likely representative of the entire population, or is it there's some selection into who participated?
Yeah, so I think you're going to get into this, but it sounds like you're going to get different numbers because different populations will have a different risk of long COVID. People are defining long COVID differently in different studies. So both of those can contribute to getting different estimates, and not to mention the variant.
Yeah, so these are all reasons why in one study you might see 50% of people get long COVID, or down to 5%. And so keeping all these factors in mind. And there's actually a really nice piece that came out from Stat News that I have here, if you want to also link to
Okay.
that in the chat, that sort of gives a good summary of a lot of these points that I just raised. So given all that, getting back to that, the other part of the question is, how common is long COVID then? I think we had a recent study in the US of 60,000 adults carried out by the CDC in June 22 that found 1 in 5 cases reported yes to the question, did you have any symptoms lasting 3 months or longer that you did not have prior to having COVID-19? And they also estimated that 7.5% of all adults, or about 20 million people, are living with long COVID right now. This is a survey that they may have had some issues with response bias in terms of not being quantitative, and that's contrasted with a study that came out in the UK of a very population representative sample from the Office of National Statistics, and that estimate was that 2.8% of the population were experiencing self-reported long COVID, or symptoms that had lasted more than 4 weeks after their initial infection. So there's a range, right? And I think the thing to remember is that even in the UK, 2.8% of people is 1.8 million people estimated to be living with long COVID. And so, there may be a range of prevalence, but even a small proportion of a large number of people who've had COVID suffering from long COVID is going to have impacts. One other thing to consider is that some studies are asking how whether the symptoms people are experiencing is really affecting their day-to-day activities. And so this is another important distinction, I think, to consider is, not just whether people are having symptoms, but whether that study looked at the sort of impact that's having on their daily life. And in that UK study, 67% of those that self-reported long COVID did report that their daily activities were impacted, so that's about 1.2 million people, right? So kind of, we can split hairs, and it's important to look at the quality of studies and think about these characteristics. But at the end of the day, there is a large proportion of the population that's experiencing some kind of sequela from COVID-19 right now.
Yeah, it seems like the 2.8 in the UK, that's about the lowest number I've seen. Usually it's higher than that in different study designs.
Yeah, there's another recent preprint that is kind of looking at 10 different longitudinal studies in the UK, as well as using electronic health records. So that would be limited to people who have sought care. And those estimates are a little bit more in between, about 14 to 18% of people experiencing symptoms after 4 to 12 weeks, and 17% after 12 weeks. So another way we can kind of manage these disparate estimates is to perform a meta-analysis, or to think about, looking at multiple studies and sort of making a pooled estimate, or one that accounts for these differences in study design.
So you've been mostly talking about adults so far. So what about kids?
Yeah, so a UK study, again, I think with population representative data, but only among cases occurring up to March 21, estimated 7.8% of cases in kids resulted in long COVID, right? So, and this was symptoms lasting greater than 12 weeks. But again, this is in the almost pre-Delta surge, actually, right? So again, it's taking into context, okay, this is one estimate during one period of time in one population, but strength here being that it's a population-based sample. Another study, another meta-analysis, again, pooling estimates from across 21 studies that was published, I think, in February. So during the Deltas, but before Omicron surge in some places, or at the beginning, and this was just among European populations, they found a prevalence of 25%, right?
Wow.
So I think, I'm not going into all of the caveats of these studies, but hopefully if our readers are looking at studies, they can take into some of consideration of some of these points before they think, oh my gosh, 50% of people, versus 2%, and feel that which could be true, and I think bottom line, we're still studying this question, and studies will be ongoing to understand the true burden of it.
Yeah. And then back to where we started with the vaccine risks versus benefits. There's a lot of people that worry about the unknown risk of vaccines, but there's still a lot of we're unraveling the unknown risks of the virus, right?
Yes, I would agree. And as I try to remain as objective as possible as someone who studies other viruses and their impact on chronic disease. But it's something to consider.
Yeah, I was chatting with another one of the Psy moms about this, and that she's anticipating that this an upside of this whole long COVID will just be attention and awareness, increased awareness of that other viruses also have long-term ramifications. This is not unique to COVID.
Definitely not unique to COVID. Yeah. So the other part of this question was, what are risk factors for long COVID then? There's some variability in the proportion of people who have COVID that end up with long COVID, but some of the risk factors that are listed on the CDC website are those that experience more severe illness in the first place, seem to be at higher risk. And if you've been hospitalized or have a need to go to intensive care, people who have some underlying health conditions that they had prior to COVID-19, there does seem to be protection of the vaccine against long COVID. So people who have never been vaccinated are at higher risk. And then if you had something like multi-inflammatory syndrome during your COVID-19 illness, another sort of severe manifestation of COVID-19, that's an increased risk. The the study that was done in the US that found that 1 in 5 people have long COVID, that found that women are more likely than men to experience long COVID. There's some race ethnic inequities in terms of Hispanic adults showing up as having a longer or higher risk of long COVID than non-Hispanic white individuals or those who identify as Black. And then there was, some studies have found older age to be associated with long COVID, but then this study actually found that middle adulthood age groups were at higher risk than those that were older. So, I think we are trying to, figure out what those risk factors are. And, sadly, one takeaway is that having mild illness is not necessarily a guarantee. While severe illness is a risk factor, it doesn't mean that mild illness is a guarantee against long COVID.
Yeah. Yeah, it's a wild card, right?
Feels that way.
Yeah.
And then, did you want me to take this next?
Yeah. I've seen a couple interesting stories or news reports and scientific articles about the cause of long COVID. So if you just could take a minute to shed light on, how can a virus, that a respiratory virus have such, broad potential consequences over the long term. So what are some of the theories?
Yeah, so there are a few theories about why long COVID is occurring. One is related to the damage it causes to cells and tissues that control blood flow. And so it may have an impact on the body's tendency for blood to clot and cause sort of microclots long after the initial illness. And that may prevent, adequate oxygen from reaching tissues and organs of the body and have other impacts. Another theory is related to persistence of the virus or viral fragments that sort of linger in different tissues or organs of the body and cause the body to to sort of have a prolonged immune response to those to that virus. So it's essentially kind of, not getting cleared from the body. And both of those are related to this other theory of prolonged activation of the immune system, which may mean chronic inflammation or just sort of your immune cells responding to the virus and causing localized inflammation in places where the virus has a reservoir somehow. So maybe in the brain or, in the gut. And so, people are studying this, and, a lot of these mechanisms are, again, not unique to COVID, but this virus, SARS-CoV-2, is acting in ways that we have seen, other links between infectious and chronic disease play out. So, I think as time goes on, we will be learning more about why this is happening.
Yeah. I'm going to drop a link to that, to one of the good articles on that from Science. I think we have time for one more question.
Yes. Okay. So on a different topic, people are asking, when is the best time to get a COVID test? And Judith from Madison, Wisconsin said, I had a PCR test done the day I started having symptoms. It was negative. 3 days later, I had another PCR test done. It was positive. And I think this is, a common question we're getting, especially in relation to which variant is circulating at the time, or sort of whether you're vaccinated. So what information can you tell us, Chana, about when to get tested?
Yeah. Well, no matter which variant is circulating, the virus always goes through the same basic process. It enters your body, and then it takes a while. It's sort of at low levels, takes a while to replicate. And once it kind of gets hold in your body and kind of wins that tug of war with your immune system, it shoots through the roof, and your virus levels get really high. They stay high for a little bit, and then they start to slowly plateau, slowly taper off. And so that curve looks very similar for every variant, but the timing can shift a little bit. And what we're learning with Omicron is that actually there's also a shift in where the virus, because that curve is happening, that the viral level might not be the same in your lungs as it is in your nose. So when we're talking about rapid tests or often PCR, you need to keep in mind that you're actually just sampling your nose, but there's disease happening elsewhere in your body. And so it does seem with Omicron that tests are often taking a little bit longer to turn positive. So prior to Omicron, we often saw that right when symptoms set in was a really good time to test, and you had good chance of catching it either with PCR or with rapid tests. But with Omicron, it seems like the biology has changed a little bit, and maybe it just takes a while for the virus to get into your nose. And some of that may also be that, especially in vaccinated people, your immune system might give you a signal earlier, sort of like an early warning signal. So you're getting symptoms, but that's mostly a function of immune system activation. And then it might take a few days after that before you have enough in your nose to pick up. So the tests actually still work really well with Omicron. Like if you just take a rapid test in a lab and throw some Omicron at it, it can still pick it up really well. But the test can't work if the virus isn't actually in your nose, right? And so we just have to bear in mind that the timing has shifted a little bit with Omicron. There are lots of people that will still pick it up when they're first symptomatic, but also other people, it will take a few days. So you have to interpret that first symptomatic day test with a grain of salt. And repeat testing is really the key to having higher confidence in your results. And that's true both with PCR and with rapid antigens tests. The story of this person is not unusual, that they went for a PCR, which is viewed as the gold standard. But that's, again, it's not going to be positive if the virus hasn't really taken off in your nose yet.
Well, and I think the takeaway is if you have symptoms, act with caution to assume it could be COVID regardless of your test being negative, and then test again in a few days, right?
Yeah, exactly. So that's with symptoms. And if you've been exposed, the peak of the virus is usually 3 to 5 days after exposure. So if you have more than one test, it's worth testing on day 3. You might even pick it up on day 2, as that's what happened with my family. We got it around day 2. Day 2 to 3 is when we turned positive. But other people, it takes till day 5 after exposure. So if you only have one test, you might want to wait to minimize your chances of missing it. But if you have more than one test, you can test as early as day 2, 3, but then keep testing a few more days after that. And one more thing on timing is that if you're hosting a gathering, the best test is the one right before the event. So personally, I would much rather have a rapid test right before the event than a PCR 3 days before, because the virus might just not have had time to replicate, and who cares how good PCR is if it's not there yet. So keep that in mind if you're hosting gatherings. I was going to share a story. Maybe I'll just really quickly that we do have some anecdotes of this playing out in real life. Another SciMom who I recommend checking out, the SciMoms, Science Communication, Data-Driven Parenting. But she sent her kids to an overnight camp that was a month long, and they did screening PCR before arrival, rapid testing upon arrival, PCR again 2 to 3 days later, and PCR again 2 to 3 days after that. And that last PCR still caught people. And it's not because the previous test didn't work. It's because what if you got it on the day of travel? You wouldn't have been able to pick it up if you got it on the airplane the day that you arrived. It just takes a few days to pick it up. So timing and repeat testing is really the key to test performance. And I think things are out of time. So I could go on a soapbox forever about how awesome rapid tests are and how they need to be more celebrated.
I'm a fan if you have access to them. And we basically do rapid tests before we get together with most people.
Yeah. Well, when both times rapid tests have saved us from exposing my mom on multiple occasions when my kids didn't have symptoms and we tested just because we were seeing her. That's happened twice for us. So I think that's all the time we have for today. And so thank you so much for joining us. Just a reminder that we do have a newsletter where we share our content, if that's a good way to get it landing right in your inbox. And then if you want to submit questions, you can do that through the Dear Pandemic website. And we do read every question and use them to inform the topics that we answer in our live Q&As and our posts. So thanks for joining us.
Thanks.
Take care.